So you do a triamcinolone assisted vitrectomy with or without base shaving. Then a deep, which is a deep, by deep I mean 100%, not 60%, 50%. You keep your diathermy probe to 100% burns you have to give around the incarceration site. Then remove the incarcerated retinal tissue with underlying choroid to the level of bare sclera. Then 1 to 2 rows of prophylactic laser are done around the side. And any bleeding which happens during this procedure can be controlled by additional diathermy or by increasing the infusion pressure. So to understand the concept of chorioretinectomy, I described this first case. He's a 28 years male with a double perforating injury in his right eye. He also had endophthalmitis in this eye. So first procedure was done. We did a lensectomy, and we cleared all this fibrous or the exudative material at the wound site. We repaired the wound. And we did a vitrectomy. We cleared all the hemorrhage, all the exudates. And as the saying goes, in an inflamed eye, we did not touch the retina. We stayed away from the retina. And you can see there's a wound here, the exit wound here in this eye. And we did not do anything to this. And this was 2 months post-operative. There was a thick fibrous growth from the exit wound extending to the fovea. So this is what normally happens in this kind of deep impact trauma. There are these membranes, they grow, and they keep on recurring. You go again, you remove it, and it will again come back. And his patient, after 2 months, his best corrected vision was still counting fingers at 1 meter. And at this stage, we plan to remove this membrane. And this membrane was removed. But because the membrane is coming from below the retina, from the choroid, you can't totally remove it. So now I'm giving 100% diathermy burns around this trauma site, the exit site. And then sparing the larger blood vessels, I'm using cautery to burn out the choroid as much as possible. The choroid and the overlying tissue, and along with the membrane that has formed. So after this is post-operative, 20 days post-operative, the vision was 624 in this eye, and 2 months post-operative, the vision improved to 6/18. You can see small hemorrhages due to the BRVO which had come in this eye, but this is 1 year post-operative. There is no recurrence, and the patient is maintaining a vision of 6/18. So this case I showed to give you an understanding why chorioretinectomy is necessary. And so this is another patient, 21 years male, perforating eye injury with intraocular foreign body. And again, vitrectomy was done. The vitreous hemorrhage was removed. You can see that the hemorrhage, the foreign body was impacted into the retina and injuring the choroid also. So you need not do a chorioretinectomy in all cases, but only in cases in which there is an impaction of the choroid. And then at this side, again you do 100% deep diathermy burns. And after doing this, you plan to do a chorioretinectomy. I'm using cutter in this to remove the excise, the choroid, as well as the other tissues, the overlying. You see, you have to go deep to the bare sclera. You can see that whitish thing now visible. That is the sclera. And there is a small amount of bleeding still there, which you can easily control either by raising the bottle or by diathermy. So once this is done, after this, we remove the intraocular foreign body. This is the pars plana approach. Using the bias forceps. And then we suture this wound. And this is post-operative. The patient had a good visual recovery of 6/6 in this eye. This is another case, the 32 years male, injury with a knife. He had a retinal detachment with vitreous hemorrhage and a large area of vitreous incarceration. So again, you can see in the areas in which we have larger areas of vitreous incarceration, we can't go and remove whole of the choroid. So what we generally do is after creating the diathermy, we remove a small strip all along the retinectomy area, so all along the vitreous incarceration, and there is no proliferation seen after that. So here I'm first time doing a retinectomy, and you see there is a large area of vitreous incarceration along with the retinal incarceration there. After doing a retinectomy, I'll just take the diathermy probe and melt the choroid all around this area. Now this incarceration is free from the surrounding tissue. Now you see with the diathermy probe, I am just creating a 1 millimeter strip all along this area. And after doing this, again the same procedure is followed. You do a fluid gas exchange, you put in oil and close the case. So you need not excise the whole of the choroid here. And this is a post-operative, 2 months post-operative, the best corrected vision was 6/60. 1 year post-op, again you can see a well-attached retina, the silicone oil is removed, and the patient's vision is 6/36. So this is again 2 years, there's no recurrence, there's no growth of any, there's no PVR also. There are some more cases of in which choroidectomy was done. This was a case of iatrogenic perforation during a vitrectomy. I had injured the retina and the choroid. This is a cow horns injury. Again, you can see there's a large patch of vitreous incarceration. This is again a patient of double perforation. And some non-traumatic applications, 36 years female, best corrected vision was 6/36. I think the time is more than not 8 minutes, I think, in this. So this was a case of an angiomatosis, exudative RD and macular edema, and he had undergone multiple sittings of laser and cryo for 2 years. Multiple injections of intravitreal Ozurdex has all been given. This is the pre-operative picture of hers showing a large tumor in the inferior temporal quadrant, and there was a recurrent macular edema which keeps on coming. So we plan to remove the tumor in this case. This was a 25 gauge vitrectomy. We removed the vitreous, and then we removed all the epiretinal membranes which were present. So these membranes, so angiomatosis retina, one characteristic is there's a lot of vitreous cases, and there are many membranes which are overlying the retina, and they are very tough to remove, especially when they are present over the tumor. So the ILM peeling was done to ensure that all these membranes have been removed. And after this, you see still some membranes are left which are being removed. Then these deep diathermy burns were given around the tumor. Actually, initially I had planned only a retinectomy and removal of the tumor in this eye, but the tumor was very adherent to the underlying choroid, so I had to do a chorioretinectomy in this patient. So again, I'm giving 100% deep diathermy burns around this tumor, and then using the cutter, I'm trying to excise the tumor. Now, so infusion pressure is same, 30 millimeters generally I keep, and it's the same. And now you see the tumor was very adherent to the underlying choroid. So there was no other option but to remove the choroid as well. So we plan to do a chorioretinectomy again in this case, and we removed the tumor along with the choroid. In these large choroidal excisions, you have to take care that there should not be an air embolism occurring, which can lead to serious problems like death also. They may be fatal. So you have to take care when you are doing a fluid air exchange. It has to be at a very low pressure, and you have to do a very deep cautery all around the site, and you have to cauterize the bed also, so that there are no active vessels through which the air can pass through. So after this, again, yes, sir. It can be avoided, but this was an attached retina, so I thought I need not put PFCL and oil in this. Yeah, sure. And this is 6 weeks post-operative. The patient's vision was 6/12, and she had no recurrence after removal of this tumor. So my take-home message is chorioretinectomy is a relatively new procedure. It may prevent exit wound related PVR and fibrous growth over the retina from the wound site, and it may be considered as a prophylactic and a therapeutic option. Thank you.
Thank you, Sangeet, for your excellent presentation. Excellent. Hang on. So basically, the need for a chorioretinectomy is that once the retinal surface is breached up to the choroid by a foreign body or any other or incarceration phenomenon, the possibility of PVR increases exponentially. That arose the need for a procedure like chorioretinectomy, which prevents PVR. Just one last question before I allow you. Sengül Ozdek of Turkey, she goes to the extreme of even, suppose there is a exit wound through the center of the macula. She does chorioretinectomy around the, so would you do the same?
So I have also done that, and though I did not show that particular case, the concept is like to prevent at least the surrounding field. Okay, whatever is injured, when the choroid is injured, it means your RPE and the photoreceptors are totally injured at that area. You won't get any vision, whatever you do. So it's better to do a chorioretinectomy and at least prevent the peripheral vision to as much extent as possible.
Audience, any questions?
I have a lot of experience with chorioretinectomy, but what post-operative problem that I face, that is persistent hypotony. Hypotony. Low IOP. So it is better to maintain the IOP with the help of silicone oil only. Silicone oil 5000 centistrokes, that will be helpful.
I think if it depends like whether your retina is attached or not. I won't
Yes.
put a silicone oil just to prevent hypotony in a primary procedure. If there is a chronic hypotony, I may think of putting a silicone oil as a secondary procedure, but not as a primary procedure.
Okay.
Yeah. If your retina is attached. If it is not attached, then definitely.
So thank you so much, Sangeet. And next I invite Aditya to talk on choroidal detachments. Aditya has also made a name for himself in essay files, especially propagating the modified Yamane's technique. So over to Aditya.
Thank you, Dr. Jayanto, for inviting me for this course. So I'll be talking about choroidal detachments and the drainage techniques. So basically it's a potential space, suprachoroidal space between choroid and sclera, and abnormal accumulation of the fluid in the suprachoroidal space is choroidal detachment. It can be hemorrhagic or it can be serous. The common risk factors are hypotony, trauma, use of blood thinners, inflammatory conditions, and history of detachment in the other eye. So hypotony leads to the seepage of fluid from the choroidal capillaries that seeps into the suprachoroidal space, and that causes choroidal detachment. So we have serous and hemorrhagic choroidal detachment. In serous choroidal detachment, you have transudation of serum into the suprachoroidal space due to hypotony, and this is due to the small peripheral effusions, which are usually asymptomatic, but the larger ones require treatment. So the best treatment for these conditions is oral steroids, and these wide field fundus cameras are now extremely useful for monitoring the progress of these patients. So this is one patient where a similar thing was done. Post trabeculectomy patient developed hypotony, and oral steroids have done their job. Another patient with another extensive choroidal effusion was treated with similar oral steroid treatment and did well. And even almost 360 degrees choroidal effusion also works quite well with oral steroids. So don't shy away, even if you see kissing choroidals, to have more tolerance to the fluid, allow the oral steroids to take effect, and don't jump into draining this serous choroidal effusion, because you drain another hypotony means another chance of effusion. Now coming to the hemorrhagic choroidal detachment, the blood accumulates due to the rupture of choroidal vessels, abrupt onset of severe pain, marked reduction in visual acuity, and it is often associated with high intraocular pressure, and the prognosis and outcomes are usually not very favorable. Intraoperative choroidal detachment, you can see in a patient now. I'll show you a 40-year-old male, status post road traffic accident, came with 1 meter vision. On examination, there was anteriorly displaced IOL, and the surgery was planned for IOL explant and secondary IOL. The infusion cannulas are in place, and now I'm enlarging the limbal incision to explant this lens. And you can see the mound of choroid starting to build up because of the open wound. There is hypotonia and the cannula has slipped back. So all that you need to do here is stop, take the cannula out, suture the wound, and start the infusion from the other side. So I can see the inferotemporal choroidal effusion here. So I have started now the infusion on the nasal side, and all that you need to do is just remove these valved cannulas. The valved cannulas do not allow the drainage of the choroidal effusion, and you can see all that was required is just removal of this cannula that allowed this patient to settle, and then the surgery can be performed later immediately with the secondary IOL fixation. So with the endoilluminator, I'm just confirming that everything is okay inside, and there's not even small peripheral effusion. But sometimes we are not so lucky, and we have a patient who is one-eyed, who came with intraoperative suprachoroidal hemorrhage, and this patient was subsequently treated with this patient had to be operated as a second surgery for drainage of the suprachoroidal hemorrhage. So a one-eyed patient on anticoagulants, a high-risk patient on anticoagulants as well as antihypertensives. He also had some cardiac issues and fitness-related issues. You can see the cornea is already edematous because the pressure is very high. And since the exact duration of the surgery, the first surgery and the second surgery could not be planned, we went ahead with a conventional way of draining the suprachoroidal hemorrhage because we were anticipating some clots to be drained here. So radial incision is made onto the sclera about 7 to 8 millimeters away based on the B-scan findings with maximum area of suprachoroidal hemorrhage. I'm using the iris repositor just to drain this suprachoroidal blood. The anterior chamber maintainer will build the intraocular pressure and it will allow us to drain the suprachoroidal hemorrhage. Now the reason for doing vitrectomy here is there is vitreous hemorrhage also on top of the suprachoroidal hemorrhage. So I am clearing up the vitreous hemorrhage, and also at the same time I can see that the amount of choroidal effusion has reduced, but it's not gone completely. So I make another opening just next to the previous one. And again, by depressing it with the iris repositor, allowed some more blood to come out. Some residual vitreous hemorrhage on top of the macula, which was cleared using the cutter. As I remove the last trocar, you can see some more gush of brown colored fluid on the hemorrhage, which means even the nasal small quadrant of suprachoroidal hemorrhage got drained. The flow is much better. Cornea is clearing up. This is the post-op picture. So the indications of surgery are flat intraocular chamber, marked reduction in the visual acuity, long-standing choroidal detachment, appositional choroidals, and suprachoroidal hemorrhage. These are the indications of drainage of suprachoroidal hemorrhage. So it comes from various etiologies. Most commonly encountered is glaucoma surgery, especially hypotonia, inflammation, or both. While choroidal effusions can resolve spontaneously, surgical drainage may be necessary in some cases, as I showed, and it can result in good visual acuity if timely treatment is carried out. Thank you.
Thank you, Dr. Aditya. Any comments or questions?
At the end of Shubhendu's, combine the choroidal detachment.
Right.
Okay.
Okay. Thank you.
Thank you. So now I invite Dr. Guha to present on subretinal PVR. Dr. Guha, as we all know, is a prolific retinal surgeon and practicing in Delhi. And he is the champion of subretinal surgery, I may say. Sir, please.
That epithet goes to you. Anyway, so good morning all, and thanks for all those who could make it to this hall to hear us for this course. And so without much ado, subretinal PVR. These are the two institutions I am grateful to, because I am from Calcutta, and Don Bosco School, Park Circus, and National Medical College is the two institutions I owe everything to. Now, subretinal membranes we know are retrolental bands of membranes, and there are known complications of regarding and trauma, and as a part of spectrum of the PVR. And the RP cells, we know the pathogenesis migrate from the normal monolayer into the subretinal space and undergo metaplasia, which is also called epithelial mesenchymal transition of the RPE, which is involved mainly in the PVR formation process. Two types, diffuse cell sheets, which these glial cells, they lack collagen, so they don't contract, they're not really contractile. So sometimes they do not need to be removed, most often. Not sometimes, most often. The taut membranes are the second group, containing mainly myofibroblasts, 95% derived from RPE, and also containing fibrin and collagens type 1 to 4. These are the ones which usually requires division or removal. These are the morphological types. We don't want to go into detail. We all know. Now this is very important. Lewis reported that only 28 to 30% of the subretinal strands actually require removal or transection, and patients who do not require removal or transection have a relatively better prognosis. So this is an old publication. So since then, much water has flown down the Ganges, and right now, even after we remove, the prognosis is quite good. So we should also know when not to remove subretinal bands. For example, this is a band. As I play the video, you will realize this is coming subretinally from the macular area right up to the periphery. Now, if you do a simple test of depressing, you put PFCL after doing a thoravitrectomy, of course, clearing space for the PFCL, and then you depress, and then as you release, if it still remains taut, then you must remove. If it, the band plays along with the depression, then most of the cases you just need to do a barrage around the bands and not, as you see. So you have to go posteriorly and then come in these type of situations. But it's very important to remove the vitreous base, as you would see. So surgical principles are the same as any PVR, closure of brakes, release of traction. And preventive aspects we won't deal much here. So key points are sheets never cause enough force, plus bands often have to be removed. Like these sheets can do well with buckling surgery alone. You can see. Now, if the band is next to a brake, a retinotomy might not be required. You can remove it through the adjacent brake. But if a retinotomy has to be made locally, then it should be near a band and never over a band. And the site should be chosen as such that you can apply tangential force to remove the band with your forceps. Like, for example, in this case. Now, these are the various maneuvers one can adopt to unimanually and also bimanually, as I will show in the video. So, but it's always preferable to use a wide-angle system to see the remote effects of your localized actions. That's the beauty of the wide-angle systems. And never use diathermy, I want to re-emphasize, over a band, so that you can sever the band and spoil your surgery. Now, sometimes the band is strongly attached through various attachments to the RPE. So it's better to cut these bands and not to remove toto, because it might lead to bleeding and other complications. If there is a diffuse network, as you would show in the video, of subretinal proliferation, then you would often need to do a thorough retinotomy, which if you do a retinotomy in a large network, as you would see, it has to be 360 degree. It's better to do a 360 retinotomy so as to release all the tractions and do it under your direct vision. There has been a paradigm shift. I call this technique a tug of war, initially propagated also by Dr. Cyrus Schroff, but I extrapolated to deal with subretinal PVR also. He started using retinal membranes, so where I use two forceps or a combination of forceps and spatula. And this is that band, which has to be removed. So it is tenting up the retina, as you could see. And so it's a 360-degree network of bands going down to the macular area. I had to do a 360-degree retinotomy, and by tug of war technique, it's just you use two forceps or a combination of forceps and spatula and pull tangentially, never in any other direction, just tangentially. You would see the one part of the band will definitely give way. The beauty of retinotomy is that you can have access posteriorly also if you want to remove any subretinal element, but be very careful. So you can go right up to the disc sometimes and remove the submacular bands. So you put PFCL and then settle the retina, do a thorough laser and PFCL silicon exchange. And so these are the tricks of doing a retinotomy. You do radial cuts to release the vector forces, otherwise there will be later PVR changes and the redetachments. So this aspect I wanted to highlight, radial retinotomy at the inferiorly into two sides, if it's a 360 retinotomy. Of course, this is a case which presented to us, repeat surgeries elsewhere. I removed the oil went subretinal, and there is a huge, you can see the huge amount of subretinal. I did a 360 retinotomy, removed it by using this bimanual technique of tug of war, and you have to be very patient and very careful as you are approaching the macular area, submacular area, so that you get a settled retina at the end and silicone oil is put. So I'll go to the next. This one I want to touch upon, ab external removal of subretinal bands, started by 2015. So these are novel techniques. Rupok, my friend, does it quite often, I believe. I still remember Rupok's lecture in the last WBCO7 on this. You were clapping at every step. Yeah. So, yeah. So, the highest area of detachment is identified, and the trocar is advanced at the 15-degree angle, almost tangentially. And then you insert the forceps and take out, of course, the attendant problems for injury and subretinal bleeding is always there. These are just a pictorial representation how to perform the technique. You go subretinally, pull out the band. It avoids the need of multiple resurgeries, but severe, these has limitations. Severe PVR, prominent retinal shortening, resolved folds, shallow detachments are not to be done. This is not to be done. Membrane is usually removed first, and then vitrectomy is preferable because of these reasons. This is the last video. So you do have to perform the localized retinotomies and localized, if there are just localized membranes, subretinal membranes, you do a retinotomy as I showed in that way. You choose the site carefully, and in these cases you do a thorough 360 retinotomy and then do the, as I shown earlier also. But these are few cases which are atypical in the sense that one of the cases involved a huge macular hole, massive macular hole, and more than 3,000 microns diameter with subretinal PVR after repeat surgeries elsewhere, and there it is orthodox retina transplant also along with it, and the last is a foreign body. So you have to be careful. These at the periphery edges also PVR, they have to be removed tangentially. These are neither subretinal nor epiretinal, but sorry for the slides. So sometimes the folds disappear when you. Patiently working with these membranes, and this is the case I was referring to. So subretinal PVR with rear detachments with a huge macula, you will see the hole shortly. So there was already a so I just detached it from the edges. And this is the retinal transplant that I am placing in position. Taking from periphery. Last but not the least, in a case of foreign body, you would also encounter subretinal PVR. So after removal of the foreign body, you would go in and take out these subretinal membranes. There was already a pre-existing break, so it was not difficult to maneuver. Unfortunately, this foreign body was lost very near the fovea, so the visual recovery was not good. Thank you so much for your attention. So, next I invite Dr. Vishal, esteemed faculty from MVP, and we would be speaking on choroidal biopsies. Over to you, sir.
Thank you, Dr. Guha, for the kind invitation. So yes, all the talks what were delivered prior to my presentation were all focusing on the choroid and the retina. So the course description told me to speak something about biopsies, particularly related to choroid and retina. But I will touch something related to sub-RP because that is also very important space which is between the retina and the choroid. And being in ocular oncology, there are a lot of tumors which are kind of originating, or we assume that that is arising from that particular space. So I will be talking about something related to sub-RP biopsy also. So before I start, we all know I think biopsy is very, very important, particularly from the ocular oncology point of view. We can do biopsy particularly from the point of being to diagnose particular condition, wherever clinical acumen or the multimodal imaging might not help us to reach to a final conclusion. In some cases of tumors, even though the diagnostic is confirmation, but we need prognostication in terms of future surveillance, in terms of risk of metastasis. And very rarely we do take biopsy, which itself can be a therapeutic option for the particular case or the particular tumor. Biopsies, if you broadly classified, they can be classified either the incisional biopsy or excisional biopsy. From the scope of this presentation, I'll be limiting myself only to incisional biopsies and particularly limited to sub-RP and full thickness retinochoroidal biopsies, which can be achieved using an intravitreal approach. Before we jump into the cases and the procedure itself, I think it is very important that you know what instruments we need to have. We need to make sure that all the techniques and all the procedures related to biopsies are all in place before we jump into doing any kind of biopsy. Because once you take the tissue or the specimen, it is gold standard, and we don't want to miss not being able to take that specimen or the tissue to reach to the pathologist. So make sure that you have everything in place before we go on to obtain any kind of biopsy from the eye. For the posterior segment, usually the fine needle aspiration biopsy involves whether the tumor is located pre-equatorial or post-equatorial, and depending upon the location of the tumor, you can obtain a biopsy either through a transscleral approach or a transvitreal approach. From the intravitreal, because we all are retina surgeons, we are very confident in doing the retina surgeries. So I think being a retina specialist, it is easy for us to obtain any kind of biopsy from the posterior segment, particularly whether it is a tumor or any mass or any suspicious lesion. So we do a standard 3-port sparse plane vitrectomy. Important point is make sure that you're using a walled trocars, because always the risk of tumor seeding is always there in case of any intraocular tumor. So you don't want to miss that aspect of the tumor where you're doing a biopsy and inadvertently you're causing a tumor seeding, where you are making the case from an intraocular to an extraocular extension. So make sure that you are using ports with a walled trocars, and at the end of the surgery, make sure you're doing cryo or you're suturing your ports if you feel the scleroderma ports are leaking. So I will describe few cases. This is a case of 52-year-old female. She came with an prior diagnosis of choroidal granuloma, presumed to be tuberculoma. She already received 1 year of ATT elsewhere, and despite an oral steroids and couple of anti-VEGF bevacizumab injections, and despite all this going all across 3-4 institutes in India, ultimately she landed at our place, and this is the imaging what she already was carrying. We did only ultrasound to just demonstrate what we are looking at. So what you can see in this clinical fundus photograph is a amelanotic choroidal lesion, because you can see it is elevating from the choroid. Overlaying retina, you can see there is a bump. The retinal vessels looks normal, and there is a surrounding SRF which is leaking into the macular area. ICG, you could see the lesion remains hypofluorescence through all the phases of angiography. OCT shows a smooth dome shape elevated choroidal lesion with compression of overlying chorocapillaries, kind of photoreceptor disruption, and some amount of SRF. B scan is very, very important. What you are seeing is high surface reflectivity, and the reflectivity keeps on going down, as you can see in the corresponding A scan spike. And this is very, very classical description for choroidal melanoma, also known as angle kappa. So I think the therapeutic trial of ATT, which was done for presumed tubercular granuloma, didn't work. Anti-VEGF injection, even people give intravitreal moxifloxacin for tuberculoma, that also didn't work. And the imaging what we did at our place, it shows that this we are dealing with a mostly an amelanotic variant of choroidal melanoma. Patient was very apprehensive. We were sure that we are dealing with an intraocular mass lesion, but the patient wanted a diagnostic biopsy before we jump on to label any patient to have an intraocular tumor, which can have its consequences throughout the life. So we went ahead and did transvitreal fine needle aspiration biopsy. So what we use is a long 24 gauge needle through one of the 23 gauge trocars, and we directly go to the most prominent portion of the tumor, avoiding any major retinal blood vessels. And with a back and forth movement, what I am trying to do, the sister is slowly aspirating the material what we are collecting from the tumor substance. And this we fixed in 70% absolute alcohol and send it to pathologist as early as possible, if not on the same day. And you can see at the end of the procedure what we want to make sure that there will be some amount of bleed or some amount of blood clot on the area where that your incision was made. Make sure you increase the infusion pressure to 60 millimeters of mercury, come out and stay in that current position for 1 or 2 minutes till you look at all your biopsy material, and go back inside and see that usually the blood clot might have already kind of clotted, and there's no need to do any laser or any tampon or anything, because the underlying choroidal mass itself will serve as a buccal kind of element. It will close the biopsy site. So this again proved both the immunohistochemistry markers, melanin and HMB45, which are very strongly expressed in particular in case of melanoma, came positive, and this patient underwent required plaque brachytherapy, follow-up for last 3.5 years, no systemic metastasis, and everything going well. So this is the role of biopsy, particularly from the diagnostic point of view. From the prognostic point of view, yes, in India we don't have any very good markers from the prognostic point of view, but in Western countries they do usually prognostic biopsies, particularly for all choroidal melanomas, to look for any future systemic metastasis, risk of metastasis, and how soon they should be doing underlying systemic screening to look for any metastasis. The second topic which was given to me was sub-RP retinochoroidal biopsy. So I think this is usually done in cases which are atypical presentation, patients particularly chronic uveitis which are not responding to your first line of treatment, steroids, immunosuppressants. There is a diagnostic dilemma, and very rarely, being an ocular oncologist, I do see sometimes patients referred for a suspected or undiagnosed primary vitreoretinal lymphoma. The yield what we get from this space is very, very critical, because this is the area from where the tumor cell infiltration is the maximum. So if you just do a vitreous biopsy, the yield will be only 30 to 40%. So that's very critical where you want to obtain the biopsy, from which area you want to obtain the biopsy. So I will just jump into a few cases. This is if somebody shows this case from the retina point of view, ocular oncology point of view, you know what is the diagnosis. You see multifocal discrete yellowish subretinal lesions with overlying vitritis. Patients already have been diagnosed to have uveitis, received corticosteroids, tapering. Again, the lesion flares up. So waxing and waning course of steroid gives a positive clue that you are dealing with an underlying primary vitreoretinal lymphoma. But yes, being an ocular oncologist, for me, always biopsy is gold standard, because it is not just about the eye, it is about the patient. So always the patient wants a confirmation that yes, they have an underlying malignancy, particularly lymphoma. And you do an OCT. OCT is also a very, very important tool, which again demonstrates where these lesions are particularly located. That's what you see in this OCT, sub-RP infiltration of the lymphoma. So what I do is a very simple novel technique. What I do, I use the soft tip cannula, I cut it and make it a little bit of bevel, and then I kind of attach this soft tip cannula to a 2 ml syringe, and the vitreous biopsy, as we do for any other case, I take undiluted vitreous biopsy followed by diluted vitreous biopsy, or the cassette fluid you can send, And last but not the least, because you can see all these lesions are in the sub-RP space, what we use is this novel subretinal aspiration cannula, which is cut and made bevel. And if you have an intraoperative OCT, that helps you to guide where you're putting your cannula. So what you will see now is I'm using this beveled cut soft tip aspiration cannula, and I'm directly going into the sub-RP space where there's a maximum infiltration of lymphoma cells. And this helps to increase our yield from 30% in case of vitreous biopsy to as close to 70 to 80%. And this I am doing for last 2 years, and this has increased our positivity rate for vitreoretinal lymphoma. So this can be without intraoperative OCT. If you have it, is good. Otherwise, it as being retina surgeon, I think we are very confident we can easily do this. So it's nothing something novel, but yes, important thing is once you obtain the biopsy, you have to make sure this has to be sent freshly to the pathologist. You have to be communicate with your pathologist and make sure that 30 minutes it reaches to the pathology. They have to look for in the cytology to look for active lymphoma, B lymphoma cells. So again, you could see in this pathology specimen, it came out to be diffuse large B cell lymphoma. Patient underwent 3 cycles of biweekly methotrexate and it responded beautifully to the treatment. Last, I am just going to show one case about VKH. This was from the UVIT clinic. Patient was already diagnosed with VKH. Multiple vitreous biopsies were done. However, every time it showed inflammatory precipitates or inflammatory debris and no atypical cells were seen. OCT again showed some kind of infiltration in the sub-RP space. So in this case, I couldn't do vitreous biopsy because already multiple vitreous biopsy attempts were done. So I'm sure that I'm not going to get anything from the vitreous specimen. So I directly went and did full thickness retinal corridor biopsy. So this is the video which just shows how we do retinal corridor biopsy. So important point again from the ophthalmologist point of view, make sure you choose an area. It is kind of very close to the posterior segment because you are not going to use any tampon or anything. If you do in the periphery, there is a high chance patient might develop regmatous retinal detachment. Second point, important, make sure you always choose an adjacent normal area of the retina when you're taking retinal corridor biopsy, because the pathologist always wants to compare it with the normal adjacent retina. So you do your normal diathermy as Dr. Mittal was showing, same thing, you do diathermy all around your area of interest, and then you use scissors to take small amount of retinal tissue. I'll just skip, yeah, small amount of retinal tissue from the area of interest, and then what you again use a MVR blade, slice onto your underlying choroid, do cautery and take small amount of choroidal tissue also. So here I'm not only just kind of limiting myself to retinal biopsy, but retinal as well as the choroidal biopsy. So you will see, you can see I'm just taking a small amount of choroid also, and this case again proved out to be primary vitreoretinal lymphoma. So you can see that in cases even your multiple vitreous attempts or biopsy have come negative, if your clinical suspicion is very high and patient is not responding to your treatment, I think you need to kind of devise an approach which is appropriate for that patient, and ultimately you do laser all around and you close the case under air. So last, I will just say, yes, there are some complications related to biopsy. We all need to be sure that this is the only attempt what you have got to take the biopsy. So make sure that all your instruments, all your pathologists are informed well in advance. And complications related to biopsy, yes, sometimes you do see vitreous hemorrhage, retinal detachment, but yes, they can be easily managed as we do for any other retinal related complications. So I will conclude. In ocular oncology, biopsy still remains the gold standard. Appropriate surgical technique with careful tissue handling is very important, and negative biopsy does rule out any possibility of intraocular tumors, and a multidisciplinary approach is the need of them. Thank you.
Thank you, Vishal. Stay on. We'll take some questions. Fantastic presentation. And in fact, I have learnt a lot myself.
Thank you.
So, one or two things I want to ask you. During FNABC procedure, you are using a 24 gauge needle, you said,
Yes.
and the sister is exerting suction, aspirating suction. So, of course, it's a manual suction.
Yes.
It cannot be automated. So, would you also have any modality of automated?
So we can use our vitreous infusion suction, what we have whisk, what we get. But again, it depends on what syringe you are using. So in that we use a 5 ml syringe. And these tumors or the specimen is so less, we can't aspirate that much. So what I do, ideally I would have loved to have a long 26 gauge needle. That's what I'm going to explore today in the trade area, if I can get a long 26 gauge needle, because
you can try that in the Pricon store.
I'm going to try that.
Yeah.
So because I have to we put one 23 gauge trocar and put a long 24 gauge needle through that. So the amount of specimen what we get, because the needle has a bevel edge, people use cutters also, 25 gauge or 27 gauge cutter to take the biopsies, but the bevel edge of the needle helps both the pointed edge to slice the specimen and cut it, and the sister usually what we see is just keeps on aspirating till it reaches the 2 ml. So you might not see any fluid or anything, but everything in the bore of the needle you will see some kind of brownish deposits of material get collected, and that you have to flush with either with normal
she is
saline.
aspirating till the material comes to the hub of the
Hub. It will, you will not see anything in the syringe.
Fantastic.
It will be always empty.
So the next one is that you said it's a 41 gauge, the soft tip cannula, you were
No, no.
novel.
It's a normal soft tip aspiration cannula what we use for a PVD induction, everything. Same thing.
And the principle is the same. You are inserting that cannula under that.
Under the our retina. So because if it is normal aspiration cannula, it will not go penetrate retina.
Huh.
So I just cut it, make it a little bit bevel, so it has a little bit pointed edge, and then it easily goes into a sub-RP space. So
There also, I think, Pricon, you will have some gadgets in which it's easier to insert it through the retina. They have a steel tip.
no, we don't need a steel tip.
okay.
We need something malleable. So this, I think
I was
this
just
works.
worried about the penetration part of it.
No, no, it easily penetrates. Should not be a problem.
Because as it maybe those retina is friable already.
Yes,
over
already
the
3D
tumor.
matters, so it easily penetrates.
So, and I was also charmed by the way he described the methodology and also the site that you choose for the biopsy. You choose the normal and the pathological border of the
Adjacent
lesion.
area, yes.
That's wonderful. And any other questions from the audience? Yeah, please.
So you have taken the tissue, the sample you have taken. What is the care you need to take before sending to a
Louder.
pathologist?
So make sure you communicate with your pathologist prior that you are taking a biopsy for a particular case. Ideally, the pathologist should be in your operation theater. As soon as you take it, within 30 minutes, it should be sent for cytology or cell block, depending on what you are taking. If it is a vitreous biopsy or any aspirate, usually they prepare cell block. If it is a tissue specimen like retina or the choroid, you can fix in formalin and they can do histopathological section.
If the pathologist is not in the vicinity,
Yes, so if it is not available, particularly for lymphomas, if the pathologist is not available, you are taking a biopsy in the evening when you know that you need a transport medium. So Western countries, they have cytolite, but in India, unfortunately, we don't have. Then you can fix in 70% absolute alcohol. Don't use formalin because that lyses all the cells. So 70% absolute alcohol is something what you can use for transport medium.
And also the steps that you are excising the choroid in the retinochoroidal biopsy. Too much use of diathermy will destroy the cell. So
Yes.
you have to have balance.
Yes, so you don't want bleeding also to happen and you want adequate
Balance.
tissue specimen.
So last,
yes.
while dealing with Dr. Sangeet's videos,
Yes.
I was referring to you. So any tips for avoiding air embolism? One of them, I've heard somebody ligating the vortex veins, something.
Not ligating the vortex veins. So what Dr. Mittal had shown is a beautiful video of retinal angioma where he went and did endo resection kind of thing and kind of eat it away. Either you can endo resection or you can do end block resection and keep it out. Main thing is the bleeding because these are all not kind of normal retinal vessels.
To avoid
They are-
air embolism.
So air
what are the-
embolism, you can use PFCL, but again PFCL is also dangerous. People have shown reports where
Yes.
even PFCL itself is a gas. So this gas itself can go through your vortex veins or scleral perforator veins and cause air embolism. So you have to make sure you have to tell your anesthetist to be standby whenever you're doing any kind of large endo resection. Because I do choroidal melanoma endo resections, I make sure I keep the anesthetist informed that this is I'm going to do. The BP should be as low as possible. So you can't do all these surgeries, intraocular surgeries, particularly where you're doing retina or the choroid excision and your blood pressure shooting up. So make sure you keep your anesthetist well informed what you're going to do and you observe these patients. If required overnight, you can admit them and see them next day.
Thank you so much, Vishal.
Thank you.
Perfect. Subhendu, suprachoroidal hemorrhage. Subhendu is a bride from Canada, my hometown.
So very good morning, everyone. So I will talk about the suprachoroidal hemorrhage, that is expulsive hemorrhage. I think it's a little bit overlap between the Dr. Kelkar's topic and my topic, but still, these are all varieties of condition that you should experience. Okay, yes. This is the suprachoroidal space. It is a potential space between the sclera and choroid. Normally, it contains actually virtually potential space that contains 10 microliter of fluid. And suprachoroidal hemorrhage is a rare condition defined as a collection of blood in the suprachoroidal space that is in between sclera and choroid. The incidence after ocular surgery, it is 0.04 to 1%. The common predisposition factors, for the development of SCAs, that is suprachoroidal hemorrhage, are advanced stage, glaucoma, increased axial length. In myopia, it is also reported as an increased risk of suprachoroidal hemorrhage is there. Poorly controlled hypertension and diabetic mellitus, because the arteriosclerotic changes, it make the arterial wall more stiffer, and aphakic state, history of vitreous loss, use of anticoagulant or antiplatelet medications. So what are the signs of expulsive hemorrhage? It is like you should be always, the condition should be always in your mind. What are the signs? Like if the AC is shallowing and there is bulging forwards of the iris diaphragm and vitreous starts swelling out of the limbal section, iris prolapse, and there is prolapse of the vitreous through the wound. So all these things are very much detrimental for signs, that is ominous sign for development of this expulsive hemorrhage. The primary management, it is obviously tight closure of the wound, because you have to make the eye absolutely airtight, and posterior radial sclerotomy immediately after during the surgery. It is also an option, but still posterior or radial sclerotomy, people are hardly nowadays doing it. So a common indication for surgical drainage of suprachoroidal hemorrhage are extreme, the patient is having extreme pain, persistent flat anterior chamber, uncontrolled elevated intraocular pressure, retinal detachment, central choroidal apposition, retinal or vitreous incarceration in the wound, or inability to deposit all the intraocular contents. So for secondary management of expulsive hemorrhage, it is always necessary to refer to a VR colleague. Post-operative, anytime you can do it till 2 weeks, and ideal time for the drainage, it is 7 to 14 days prior to surgery, after primary surgery, because for the adequate clot lysis it is required. So surgical management described earlier, it was the radial sclerotomy combined with vitrectomy and use of perfluorocarbon liquid and silicone oil. So that is, you are doing the radial sclerotomy and using this cycloanalysis spatula, what Dr. Kelkar was showing, that using the spatula, and you can just keep the one part of this scleral wound depressed, and so that the intraocular the blood clot from the supraocular space will easily come out. So use of anterior chamber maintenance is another option, and SCS drainage through the anteriorly placed 23 gauge non-valve cannula, followed by vitrectomy and PFCL, along with ending with the silicone oil. So our technique was to inject, after doing vitrectomy, inject PFCL inside the vitreous cavity, and keep make a posteriorly placed non-valve trocar cannula inside the supraocular space, so that externally passive drainage of blood will be possible. So like in this case of expulsive hemorrhage, you can see preoperatively there was almost like kissing choroidals. So I put all the trocar cannula complex into 23 gauge surgery, and make sure all the trocar cannula complex are inside the vitreous cavity, and there is a lot of vitreous hemorrhage. You can see the temporal, there is huge choroidals, hardly you can see anything. So I go through the temporal side using the 23 gauge trocar, then remove the trocar, and then the injected PFCL from inside, and external passive drainage of blood was possible in a sutureless way. Now remove the PFCL at the end of surgery, and inject silicone oil, especially 5000 cc stroke at the end of surgery, so that it is not necessary, it is not mandatory to remove all the suprachoroidal blood in a single go, but still by the period of time, this suprachoroidal hemorrhage will be vanished. So this is the preoperative picture. You can see ACIOL, hyphema, and hemorrhagic kissing choroidals, vitreous hemorrhage, retinal detachment, and posteriorly there is no suprachoroidal hemorrhage in the right side. You can see there is, and in the ultrasonography, although I have not removed the oil after the surgery. So this is another case where initially I tried with started the case with the AC maintainer, and there was 2 quadrant expulsive hemorrhage. So I from the temporal side, I put the multiple trocar cannula complex posteriorly placed 10 millimeters behind the limbus into the supraocular space, and remove the trocar blade multiple. You can see the dark color blood is coming out, and after completion of vitrectomy, inject the PFCL again, and external passive for the external more passive drainage of supraocular blood in a sutureless. So you can see the dark color blood is coming out, and finally and removed all the PFCL and inject silicone oil at the end of surgery. After 3 months of doing this primary surgery, I gone for this oil removal followed by glued ion implantation. And at that time, the expulsive was almost nearly resolved. You can see that I have confirmed preoperatively and so on intraoperatively. And patient finally gained excellent vision, 6/9 finally. Patient recovered from this devastating situation. This is another situation where hemorrhagic casing choroidals and total retinal detachment you can detect on the ultrasonography. But amount of expulsive hemorrhage and amount of detachment, it's not well understood. So you can see the slit-like anterior breaks were visible in the periphery, and after doing vitrectomy, I just marked my cauterized these breaks and then try to find out what is the disc and inject PFCL just over the disc to visualize it. And slowly you can see the fluid is coming out through the anteriorly pressed breaks, and I have aspirated it out a little bit. Then you can judge the actual elevation of the suprachoroidal is not that much. So this detachment was more, suprachoroidal was less. So I settled the RD, and you can see this underlying expulsive drainage is also is visible. Now I have already injected PFCL. Now I have to do the peripheral vitreous base excision as much as possible. It's not always possible to do the vitreous excision very thoroughly, especially in a geopathy situation like this. And then I introduce my trocar corona obliquely into the suprachoroidal space and remove the trocar blade for the external passive drainage of blood. And blood was not that much, but still I drained it a little bit, and then I settled the retina and do laser at the end of surgery. I remove PFCL and injected silicone oil 5000 centistroke. This is the preoperative condition, and this is the postoperative situation. And this is another case where 78 years old lady with history of attempted phaco came to our clinic with residual lens matter and a lot of appositional choroid. You can see expulsive hemorrhage. So I started the case with 25 gauge trocar cannular complex. And even when I am just putting my trocar cannular complex, the little bit of blood was coming out. Then again, I started with the AC maintainer. Then I removed all the lens material, residual doing lensectomy, and did vitrectomy. And there was again retinal detachment as well as expulsive. This combination, deadly combination, I should say, because all these situations carrying very poor prognosis. Then I introduced my trocar cannular complex obliquely into the suprachoroidal space, posteriorly placed maculas. So, and you can see the dark colored lyse blood is coming out. If you do this kind of surgery, initial period just after 3-4 days of surgery, the blood will not come out because a lot of blood is already in clotted state. So you have to give time for the clot lysis. Then I'm doing some kind of gentle massage just to mobilize the suprachoroidal blood into the choroidal, like this 25 gauge port. And again, I put, so multiple cannular drainage, it is possible to make the suprachoroidal blood as much can be drained as possible. So 23 gauge, initially I started with 23 gauge, then I shifted to 25 gauge. Over the course of time, it is nowadays 25 gauge. 23 or 25 is good enough. Is good enough. So I completed my vitrectomy and made one small retinotomy in the supratemporal quadrant and injected the PFCL. Again, PFCL guided blood drainage was done, and you can see the slowly, still the elevation is not gone. So I again put one more port for the more complete drainage of suprachoroidal blood. And finally, I can see the macula. So now I put one 6 millimeter 23 gauge long trocar cannula to make the infusion port inside the vitreous cavity. Then I drained all the subretinal fluid and removed PFCL, did laser as well as around the break, and finally injected 5000 silicone oil at the end of surgery for the constant endotamponading action for quite a long time. And finally, you can see after 3 weeks, patient gained 4/60 vision, and after 8 weeks, patient gained 6/24 vision. So you can see the oil and retina gap is still there because the choroidal has gone, retina is attached. Now there is volume deficit kind of. So this is the good prognosis. These are the cases, 2 quadrant cases, and bad prognosis is always the hemorrhagic choroidal retina incarceration, kissing choroidals. These are all bad prognosis cases. So we have published our technique in IJO in the year 2021, and so take-home message of postoperative suprachoroidal hemorrhage are always and can be salvageable. So modified posterior drainage of SCH is beneficial, and multiple cannula guided drainage is required to complete drainage of in a sutureless way. Thank you.
Thank you, Subhendu. And you know, what a transformation in the prognosis of the suprachoroidal hemorrhages. Few years back, we used to lose all these eyes. Now we are salvaging most of these eyes. It's a fantastic. You have shown the way forward. Subhendu.
Thank you, sir. Thank you, sir.
Thank you. So we have just enough time. Nishikant Borse could not make it to come to this meet, but I have requested Sangeet to present a few things regarding submacular hemorrhage. And if time permits, I'll show my video at the end, otherwise it's yours. And Sangeet, I've requested him to show a technique that he has innovated for TPA injection inside the OT, how to manufacture that needle and syringe.
Can play the video. It's just a video. You can play it. Yeah, you can have some audio with there's audio and also. Video with the audio. Huh?
66-year male, who had undergone multiple intravitreal injections of Avastin, presented with persistent submacular hemorrhage. 27-gauge vitrectomy was done without base excision. Internal limiting membrane was peeled using ICG dye. A 40-gauge microcannula was used to inject TPA into subretinal space. TPA is used in the concentration of 12.5 micrograms in 0.1 ml solution. TPA is injected till it covers whole of the submacular hemorrhage and reaches beyond the temporal arcades. Fluid-air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. Visual acuity improved to 6/36 after 2 weeks and to 6/24 after 4 weeks of surgery. The most common complication seen with this procedure is a macular blowout resulting in a macular hole. This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of a 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 ml syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the VFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. A 42-year female presented with macroaneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27-gauge vitrectomy was done without base excision. PVD was induced with the help of triamcinolone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. A 40-gauge microcannula connected to the subretinal injector was used to inject TPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid-air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6/12 at 4 weeks post-op. These are a few more cases of submacular hemorrhage treated with the same technique. Let's see if the subretinal injection of TPA is a viable option for large submacular hemorrhage or a retinectomy with drainage is needed. 85-year male, presented with complaints of sudden decrease of vision for 10 days. He was diagnosed as massive subretinal hemorrhage secondary to IPCV. Incidentally, he had undergone retinal surgery for vitreous hemorrhage, retinal detachment and subretinal hemorrhage in other eye too about 3 months ago. We plan to do vitrectomy with subretinal injection of TPA in this eye. After completing vitrectomy without base excision, ICG-assisted ILM peeling was done. TPA in the dose of 25 micrograms in 0.1 ml was injected subretinal using a 41-gauge microcannula. Subretinal bleb was raised slowly with the help of a self-made subretinal fluid injector. The injection was done at 2 different sites. Fluid air exchange was done. 20% SF6 gas was used as tamponade. Patient was advised prone positioning postoperatively. 3 weeks post-op, significant reduction in subretinal hemorrhage was seen. 6 weeks post-op, subretinal hemorrhage had resolved and visual acuity improved to 6/9.
Thank you, Sangeet. I think the people for the next session have already come, so we have to draw it to a close. Otherwise, I was going to show you the
Next
my
session
journey.
starts at 10 only.
Huh? I think we have time. Okay, so excuse me, वो सबमैकुलर हेमरेज वाला वीडियो दिखा दीजिएगा. दिखा दीजिए. I'll just try to show you my journey. 9:45. Oh, then please. Thank you so much, everybody. We conclude here. Thanks, everybody, for being a part.